Good afternoon, everyone. This discussion is about patients who are preoperative, and also what happens to the patient when they're in the operating room. One of the first things that you just really need to understand and commit to kind of a concept memory is the idea of informed consent. So, informed consent is written permission signed by a patient, guardian, or whoever holds power of attorney for a patient. The consent is for the surgery. The written consent protects a surgeon against claims of unauthorized surgery and provides the patient an opportunity to exercise his right of informed consent. So here's what you need to know as a nurse. It is the surgeon's job to explain the procedure, the risk, and the benefits. The nurse only witnesses the patient's signature. That's all you are doing. That patient must be mentally competent and give his consent freely and without coercion. If you don't know what coercion is, that's when you're trying to lean on somebody to get them to do something. That consent form, when they sign it, is attached to their chart, or if it's hooked in, it can be scanned in and it's sent with it went to the operating room with the patient. Something for you to think about in addition is that the nurse must always check that the consent form has been signed before giving any preoperative medication. I'll let you ponder that one. Why? The other thing to think about is at some point you're going to take in a consent form to someone and the patient is going to refuse to sign it, and that's okay. Your next job would be to note that in the nurse's notes that the patient refused, and also to notify the surgeon of who is listed as the surgeon to perform the procedure. Again, clinical cues, both from your textbook and from real life. That patient has the right to change their mind and revoke consent up until the time of surgery. If that patient tells you the surgery is not wanted, delay any other preoperative preparations and explore the issue with the patient. I usually do, hey, tell me what's going on. If it appears the consent for surgery really is being revoked, you just call the charge nurse and you call the surgeon. A little bit about food and fluids. Most patients have to restrict for an 8-hour period before their surgery and take nothing by mouth. That's NPO. I have seen a restriction of 12 up to 12 hours before surgery time. It depends on the surgery and it depends on the doctor. I have seen occasionally where they allow a light meal like toast and clear liquids up to 6 hours before surgery. And I have also seen that now they are now allowing clear liquids such as black coffee, tea, apple juice up to 3 hours before surgery in an elective case. So let's talk about this a little bit more. Often the surgeon will allow you to give an oral blood pressure medication or a heart medication to be taken with a sip of water the morning of surgery. You would always want to check the physician's order before you did anything like that. And the other thing would be you would want to check the patient's blood pressure. Some people can have a very high blood pressure before surgery. Some people may be very low. Because remember, we're restricting their oral fluids. We're trying to prevent them from getting nausea, vomiting, and aspirating into their lungs and getting pneumonia. If the patient has not remained NPO for the prescribed period, they may cancel surgery. You usually have to confirm with them that they did follow the NPO, whatever their restriction was. Every now and then you meet someone who went and got like a Taco Bell at 11:30 last night, and when they get back to you in the post-operative area, they're vomiting heavily. So you want to make sure when you do your preoperative teaching that you make sure the people clear that, don't stuff themselves right before that 12 o'clock, that midnight time when they have to be in PO. And the other thing about food is insulin may or may not be given. It's going to depend on the patient's blood sugar. They may, they'll check it very frequently in this period. If a patient has abdominal or colon surgery, I've seen them give enemas, but most often what I've seen them give is a product called Go Lightly. And basically Go Lightly is a very large container. I'm going to say it's more than a gallon, and you drink that Go Lightly, and patients do just what it says. They go lightly, and they drink it until they have clear, and whatever's coming out is clear. Okay, so henceforth the name Go Lightly. Um, and they will not allow them to have a full diet. They may be just on a liquid diet for like 3 days before their surgery, because what they want to do, they want to decrease the contents of the bowel. They don't want to go in there and get into the bowel and have something leak out and, start to have infection and sepsis issues. If you read in your textbook, you're going to see a copy of a pre-operative checklist. Anyone going to surgery has this checklist. I've actually seen a checklist on paper. I've seen one come up in the computer. Either way, you have to check off when things are done. Some of the things are minor, like remove dentures. Some of the things are more like patient has voided. So talking specifically about voiding, we normally ask the patient to get up and empty their bladder, because if they don't empty the bladder, once they get under anesthesia, they'll suddenly have the urge to have to go pee, have to go urinate. And we also want to make sure that they get up and they go to the bathroom, empty their bladder before we give them any sedating medication. Many times the surgeon will order a patient-controlled anesthesia pump for a patient to use postoperatively. If that PCA pump is ordered, we should talk to patients and instruct them before surgery about the pump and how to operate it. If the patient receives injections for pain control, we want to make sure they know that this medication is ordered as needed, approximately every 3 to 4 hours, and that they must ask for it. The thing to keep in mind about teaching these things to these patients is they normally don't come in before surgery the night before. They used to. They would come in on, maybe your surgery was scheduled tomorrow on a Friday, and you would come in on a Thursday night, and we would be able to talk to patients about these types of things, about how we control your pain and what to expect after surgery. But patients don't do that anymore. They come to surgery through a department called the same day surgery department. So that same day surgery department usually has people come in and they do a lot of teaching there. They have the person come in, you go into same day surgery, and they run your test and do your preoperative blood work and do any teaching they need to do before you come to the hospital. If a patient is on an oral pain medication, it's usually ordered every 4 to 6 hours, PRN. So you have to kind of explain to your patient and that he needs to ask for the pain medication before his pain becomes severe. It does make it easier to control their pain level. You have to kind of teach the patient about the pain scale and how to use it. The biggest thing you'll hear from people is they'll say, well, I didn't want to get addicted to pain medication. I've heard that. And they need to understand, that that's not going to happen, that we do want to medicate them. We need to get them up to the chair. And so we need to have their pain under control. We need to have them cough and deep breathe. We need to have their pain under control. For skin preparation, the night or morning before surgery, the patient may be asked to shower with, it's a product called HibaCleanse, and that HibaCleanse is removes as many microorganisms from the skin as possible. I have occasionally on the morning of surgery seen that hair might be removed from an operative site. It's usually done in the surgical holding area. Nail polish has to be removed so the pulse oximeter can function correctly. You have to have makeup removed. You need to note the presence of any permanent makeup. You have to ask about contact lenses and have those removed. Occasionally I have a lady who has spent a ton of money on her nails and they won't want to take their nail polish off, so normally you can just take off the nail polish on one finger. Something else that we do during preoperative teaching is to teach a patient correct breathing, coughing, turning, and leg exercises. These are high priorities during that we need them to do during a postoperative period. Sometimes it's nice to have a relative or close friend present so that person can give coaching and encouragement to the patient. The correct breathing and coughing is to prevent pneumonia and atelectasis. The leg exercises is to try to help prevent a DVT. Venous return is often hampered during the surgical procedure because of the position assumed on the operating table. You have pooling of blood in the lower extremities. You get stasis of blood, and it puts the patient at risk for a thrombophlebitis. We do the specific leg exercises to help prevent this, but the big intervention that we do to prevent DVT and thrombophlebitis is something called an SCD. It's called sequential compression device, and if you've never seen one, you should go online and pull up a picture or look in your textbook. It's a thing that kind of wraps around and puts pressure on the back of your calf to keep that blood returning from your lower legs. If you have a patient and you need him to do his leg exercises, I always go in and show them how to do the leg exercises, and I ask for a return demonstration. I do this preoperative, and if I have done it postoperative. And one way that I remind patients to do the exercises, I tell them to exercise whenever they see a commercial come on the TV. And the books actually tell you the exercises should be done after surgery, at least 5 to 10 times every hour while awake until the patient is up and moving around. You can actually see some pictures of these exercises in your textbook if you want to take a look at them. Remember, if you go and you teach an older patient, when you go to teach them teach needed information, you have to do it in short segments to prevent confusion and make sure they comprehend. And I would think that you would understand that being nursing students. It helps to have a written reminder of any key instructions and be able to and give that to the patient. I have a vocabulary word for you. It is from your textbook. Atelectasis. It's a complete or partial collapse of the entire lung or area of the lung. It occurs when the tiny air sacs within the lung become deflated or are possibly filled with alveolar fluid. Atelectasis is one of the most common breathing problems after surgery. So what we do to help prevent that, we do the breathing exercises you see in your textbook, but a lot of times the patient will be given an incentive spirometer. If you're not quite sure what they look like, you should take a look at one in your book. It looks like a little plastic machine with a mouthpiece on it. You see a lot of times at patients' bedside. It's not something that you blow on. I'm sorry about this. It's something that you suck in on, you breathe in on. Sorry for the word suck. You have to sit up and away from the mattress, put the mouthpiece in your mouth, cover it entirely with your lips, and take a slow, deep breath and hold it for at least 3 seconds. And when you do that, you're inflating your lungs. And then you exhale slowly, keep your lips puckered, and try to breathe normally for a few breaths. And that'll open up down there that lung area that's trying to collapse. The family usually comes with the patient to the hospital. I'm going to say 1 to 1.5 hours before surgery. The family will need to be told about usual routines that we have, where they need to wait, the approximate time before the patient may be returning, and what to anticipate in the way of tubes, equipment, and what the patient looks like. We want to make sure that the family has a little bit of knowledge. This knowledge keeps this patient from thinking the patient took a turn for the worse if they see extra equipment or oxygen or IV. Sometimes the anesthesiology department will keep a patient down in the recovery room, and you have to let the family know those occasional delays um, doesn't mean that anything's gone wrong. If you give them a warning about occasional delays, maybe there's been a slow start to the surgery, it stops the anxiety of the family member coming up and driving you crazy at the desk. Immediate before we go to surgery, the patient is dressed in a clean hospital gown without underwear to go to OR. They cover their hair with a surgical paper cap. If they have long hair, it should be fixed so that it will not tangle, and all hairpins and barrettes must be removed. You will have to ask about body piercings in the presence of piercing jewelry, including the tongue, and genital areas. All jewelry has to be removed for safety because of the electrocautery equipment that is used during surgery. There is a danger of an electrical burn from conduction of electricity through metal. Any jewelry, along with money, credit cards, needs to be given to a family member or relative to keep, or you need to secure it in a valuables envelope and put it in the safe at the hospital. If they have a wedding band and they want to wear it to surgery, you have to tape the ring to the finger without restricting circulation. Dentures are removed. They're put in a labeled cup. They keep them in a designated place. And sometimes, once in a while, I've had an anesthesiologist leave the dentures in place to help be able to give anesthesia by certain types of mask. If a patient has a hearing aid, we can sometimes leave the hearing aid in place. You need to leave a visible note on the front of the chart and make sure that the placement of that hearing aid is noted on your preoperative checklist. You have to verify that the identification bracelet on the patient matches the chart to avoid any error or mix-up of patients in the OR. You have to verify that the procedure site indicated on the surgical consent form is the same as what the patient states. The procedure site should be verified and marked on the patient before transport to surgery or the preoperative holding area. So, for example, they will ask you way before you are sedated and say, can you tell me what surgery you're going to have? And if you say your left total knee, they'll put a black Sharpie mark on that knee. Okay, they'll mark the site. They want to make sure that there's no errors because we've had people, sometimes people are sedated heavily and they kind of just answer anything. I want to make sure that we don't have any errors in this situation. Okay. If a patient is to receive a medication before his surgery, remember to put up the side rails of the bed rails per your facility protocol and lower the bed. Remind that patient he is not to get up without your assistance. This is a safety measure. Before surgery begins, and this is when they wheel you into the operating room, there's a timeout. And the timeout occurs during which a final verification of the correct patient procedure site and an implant is performed. Any questions must be resolved. So for me, I'm just going to tell you what happened. I was trying to get over on the table when I had my hysterectomy, and she said, stop. She said, can you tell me your name and your birthday one more time? And so I did. And then she said, can you tell me why you're here? No one says anything, and I told her, of course, and she said, okay. So she's looking to make sure that in all the there's a lot of hullabaloo going on down, a lot of people coming and going, that there's been no confusion. What I thought I was there for, what she thinks I'm there for, she holds my charts. So this timeout is super important. As I'm sure you guessed, there's an unrestricted zone around the control desk area where you can walk up there and ask a question. Street clothes can be permitted here, but they begin to have semi-restricted zones in the hallways and the outer regions of the OR. There is a circulating nurse and anesthesia care workers working in these areas, and you have to have clean scrub clothes and caps anytime you're in this area. There is a restricted zone, and it's the area surrounding the operating table and the instrument trays and table. All personnel wear scrub clothes, sterile gowns, caps, shoe covers, masks, and sterile gloves. And remember, asepsis is the responsibility of everyone that is in that room. There is a scrub person in the operating room. Their major jobs are to gather the equipment for the procedure, prepare all sterile supplies and instruments using sterile technique, gowns and gloves, and they help the surgeon upon entry into the OR. They help sterile drape the patient. They keep and maintain sterile field within the sterile field area during surgery. Major functions of the circulating nurse. She's more of a coordinator. She coordinates care, oversees the environment, and she kind of cares for the patient in the OR. She greets the patient, performs patient assessments, makes sure the consent form's signed, she makes sure it's accurate, makes sure your surgical site is marked, checks your medical record, makes sure your preoperative forms have all been completed. So let's talk about anesthesia. Anesthesia is the loss of sensory perception. The goals of anesthesia administration is to prevent pain, achieve adequate muscle relaxation, calm fear, ease anxiety, induce forgetfulness of a very unpleasant experience. One type of anesthesia is called regional anesthesia. Regional anesthesia is accomplished by administering a nerve block. It's often very more economical than a general anesthesia. This is when this is a spinal or an epidural or a peripheral nerve block. The block anesthetizes the local area or the area distal to the block. The term procedural sedation anesthesia or moderate sedation, or I've also heard the term MAC. And what that is, it's a local anesthetic agent or regional anesthesia, numbs the area, plus they give you IV sedation, and this is to provide analgesic and sedation. So let me be more clear about this. This is the sedation when the person's asleep, but they wake up if they're spoken or touched, so they can still kind of talk to you while you're sedated. And this moderate sedation is caused by special drugs and used to help relieve anxiety. This is what they give you during a colonoscopy. My son had a wound cleaned out when he was younger, and it was a really painful wound. They sedate you a little bit for that, so you're not in severe pain. There's some other. I have had some dental. Some friends have some dental procedures done where they did this moderate sedation, where you were still awake but you were calm, and you were able to get through the procedure. There is a local anesthesia. Local anesthesia is used for a minor procedure like a tissue biopsy, a cyst removal, insertion of a pacemaker, insertion of venous access devices. If someone has a local anesthesia, they can usually be transferred directly back to a nursing unit. There are some intraoperative complications that can happen. Um, there's infection, fluid volume excess or deficit, hypothermia. They can have an injury related to positioning, or the one that I want to make you take note of is malignant hyperthermia. Malignant hyperthermia is a severe reaction to certain drugs that are used for anesthesia. This severe reaction typically includes a dangerously high body temperature, rigid muscles or spasms, a rapid heart rate, and other symptoms. And without prompt treatment, these complications caused by malignant hyperthermia can be fatal. What's the thing to remember about this is we don't know that a person has this until they have surgery. They actually assess you when you go in for preoperative teaching. They say, "Did you ever have surgery before and have a problem with your temperature?" Well, if you've never had surgery before, you wouldn't have any way of knowing. So the nurses that are in the operative area, they're watching you for that. They're watching your body temperature to make sure that you don't spike an incredible temperature, and I mean a very high temperature. So make sure that you note that, because I don't think that a lot of times my nurses realize that that's something that you need to know.